So, was it Larry? You said conflicts of interest. You sort of, when you see this, it makes you worried a little bit that you didn't have any, you wished you had some. Well, you know that I've coached about 55 Little League teams. We're in the state of Alabama where we have a football team that represents excellence. And we think our university has the same type of leadership and culture where we want to compare ourselves to national benchmarks and represents excellence every year. I never got paid to coach those Little League teams, but I do now. I coach for these companies. And the funny thing is, some of these haven't even given me any money. But I coach 9 surgeons. It's been an incredible honor to coach, and they're not all academic. 2 of them are in private practice. And I enjoy it. It's been fun. We mentioned the CSATS review. This is a company, I haven't got any money from them yet, and maybe I will. But it's a company that allows you to take your videos intraoperatively and send it to them, and experts look at it and tell you what part of the operation you're doing well and what part you're not. They crowdsource it, and they send it back to you with very specific, granular details to get better. Dr. Vickers, isn't that what we do in football? Isn't that what we do at the University of Alabama with the football team? Why don't we do that in the operating room? So we've been doing that here with our residents for a few years, but not in the level that I had hoped. I'm also a medical consultant for CHS and Bev. Is Bev Bowman here? Would you just stand up and say, I'm honored to have Beverly here from CHS. It's been an honor for me to work with her and for us to work together on aligning some metrics. And so that's been great. But what I think makes UAB great is the fact that my CEO, Dr. Patterson, who's not here right now, he's ill, and Mary Beth Briscoe have come to the operating room and seen surgery. How many surgeons here have had the kind of engagement from their leaders? And Will Fernandes is just walking in now, CEO of the entire healthcare system. Larry's down here. How many people have that kind of engagement? Is Mary Beth Briscoe here? Mary Beth, would you just wave and say hi to everybody? That's alignment. That's what leads to excellence. That's the culture we need. So instead of the surgeons in the operating room getting irritated, it's about aligning. Now I also wrote this book, and I put this in here for Dr. Chen, because the lawyers make me put up this, so now I'm advertising it, and it's available in Alabamian as well as Chinese and Japanese. So, I'm going to tell you 3 stories. 3 quick stories today, and the first one is my son on a Saturday morning. Here he is making eggs. Look at the enthusiasm. Is this the surgeon in the OR coming in late? Is this the anesthesiologist? Has this process been made efficient? He goes to the refrigerator, he gets the milk. What about the eggs? He goes to the closet, he gets a bowl. What about the fork? And I'm watching him, and I'm like, bro, this is the most inefficient. Now the milk goes over here, the chocolate milk goes over there. What the heck are you doing? And the key thing he says is, Dad, I don't care. Is that what we hear from our leaders in the operating room? I don't care if we waste more time. I don't care if we're more efficient or inefficient. It doesn't matter to me. Without the athletes' buy-in, without the surgeons' buy-in, it doesn't work, does it? We have to be able to get it to work, and if we don't have the buy-in, we won't. You can't teach something until you can measure it. The second you can measure something, it can get better. I submit to you, we can measure everything we do. We can measure it. We can measure quality. We can measure efficiency. But we have to define what quality is, and as I think you've heard so well said here today, it depends on their perspective. Who defines it? So a couple days ago, I did a lobectomy. Man, I thought it was great. Selwyn, we did it in an hour and 40 minutes. We lost 20 cc's of blood. It was all done robotically. Patient went home in a day. We usually have 2 days. To me, man, it was great. Problem is, from the patient standpoint, they were upset that when they rang the bell, the nurse didn't give them the pain medicine on post-op. They wanted to spend 30 minutes talking to them about it, and we gave that better before they went home. The hospital standpoint was terrible. They spent no money. Self-pay. You know what that means? Big loser, right? So from there, I'm just being honest. That's what it was. So the hospital's not happy with me yet. I thought I did a hell of a job. The resident wasn't there. The resident got called out in the middle of the case for an emergency, started the operation and left. So from his standpoint, it was a bad operation. And the medical student, apparently I yelled a lot as he was closing the skin because I wasn't happy, had to redo the skin. That guy's probably going to ding me, sorry, Herb, on the evaluation for me there. So, not the first time. Thank you, Herb, for that wonderful support. The point is, we are going to get report cards from everybody. And that's what makes us great. I am responsible for what the medical student says. I am responsible for what Mary Beth tells me. Hey, thanks for doing a robotic lobe on a guy who lives under a bridge on I-65. I get it. It's all part of it. The problem is this. Here's the problem. We get these metrics, and here's a picture of something that we get. This is an example of the kind of metrics we get in the mail. And it looks like, oh, and it says Euro, but I switched this around, so don't be fooled. I'm not this dumb. But it says, oh, the urological services is 100%. Boy, those guys are great. And look at this poor cardiothoracic. They're losing 50. Let's give them more ORs. Now we're rewarding surgeons for being slow, maybe losing blood, maybe converting. Does that align to quality? Is that the metrics that the hospital and surgeons think represents quality? I submit to you it does not. The other report card that we commonly get is this one. We've been getting this for 2 years in our division, and I had a meeting about a year ago with one of the quality guys in our division, and I asked if anybody could tell me what these stood for. Nobody had a clue. I mean, if your son or daughter brings home a report card, and they didn't even know they were taking the class, much less what the grades were for the class, does that represent a quality metrics of their educational experience? Probably not. So that's the problem, isn't it? There's a complete disconnect between what really matters and what we think matters. We can't understand a report card, and we believe we know what quality is, but we think the report cards we have are poor reflections of it. For those of you who think that the data is accurate, it's not. Take a deeper dive. I have a couple articles down here, which I'll give to you if you want. I started off with 100. We have 260 people. We made more copies. One is the actual cost of doing a robotic lobectomy and segmentectomy. It took me 18 months to really figure it out. Dr. Kaiser, you said it. It's really hard, but we can do it if we align with our administration, and we did. And then what happens is we compare the wrong groups. We're looking at operative turnover time in the GYN operation to operative turnover time in the cardiothoracic operation with the pump. It's preposterous, but yet that's how we're compared. Then when we finally get to the correct group, the patients aren't risk stratified, and so what happens when you call the surgeon is, he's my son making eggs. And he says, this is baloney, it doesn't matter. You haven't engaged the doctors because they don't believe the report cards. And the reality is we're right. The report cards are full of baloney. But we can fix it. We can fix it, this disconnection. And what I call when there's a problem, my kids always say, every time Dad says opportunity, it means I did something wrong. That's right, brother. The word opportunity means we're screwing it up. And we want to get better. And everyone in this room is here because you're self-selected to want to get better. We want to be like the University of Alabama football team. We want to win every single year. And if one patient, we've had one death in 690 robotic lobectomies, it's one too many. We haven't had a conversion in 140 lobes. I've done 1,400 robotic operations, and we're not good. We want to get better. Everyone in this room wants to get better. But how do we do it? Well, I think there's granular ways to do it. I'm just going to tell you 3 stories. The first was that poor boy making eggs who wasn't engaged in the process. The second one is the same knucklehead boy, my youngest son. Here he is, man on third, 1 out. I mean, all you gotta do is put the ball in play. So we're losing 2-1. This is a major game. ESPN, everybody there. Strikes out. Takes strike 3 without swinging. Who are baseball fans here? Do you ever take strike 3 with a man on third and 1 out in a 1-run game? And I'm coaching third, and I just wanted to just rip them in half. I didn't. On his way to the dugout, he says to me, Dad, it wasn't a strike, it's 3 inches outside. I said, you know what, brother? One guy thought it was a strike. That's the only guy who matters. That's what quality is for us as surgeons. There's one pair of eyes that matters. It's the payer. And that's the only umpire that says what a strike is and isn't. It doesn't matter what you think. It matters what they think. But we got too many umpires. I got a hospital. I got an insurance. And over here I got medical students, residents. I got Dr. Vickers. I got Dr. Chen. I have Will Fernandy. A lot of people give me report cards. They all have different perspectives. They all see the strike zone differently. And we as a surgeon have to be able to throw a strike to that strike zone day after day, 8 to 10 operations a day. And what does the surgeon say when they get their data? Who's heard this nonsense before? That's not my data, that's wrong, man. My patients are older. No, my patients are sicker. Hey, I do complex surgery. I'm a complex surgeon, right? Right? Like, how many times have you heard that in New York City? Okay, brother, get out. I get it. That's part of the problem. We don't believe the report card, and as I said earlier, 50% of surgeons have to be below average, but I've never met one of those guys. They gotta be out there somewhere. I've seen the chart. So what's the process of fixing this? Well, the process of fixing this is 4 steps, and Mary Beth, you and I have talked about this along with others, and I'm gonna briefly go over some of it, because it really is the devil's in the details. But the first thing is to choose metrics that make sense. If the metrics don't affect the bottom line, Dr. Larry Kaiser's not going to be happy with you. Will Fernandy's not going to be happy, but it doesn't matter. If we're looking at metrics of shoe size of patients, it just doesn't matter. So it has to affect money. And then we have to also talk to the surgeons or our medical physicians, and you can do this with diabetes, hypertension. I submit to you, you can do it with everything. Back pain, etc. And what's quality. Once you get those metrics aligned, and I'll show you some in a minute, then you've got to do the really, really hard task of this. This is really difficult. You must engage the physician to get accurate data. The best way is to have the physician put it in real time and sign off on it. Because what can he say when he says the data's wrong? I'm like, bro, it's your data. That too. You gave it to me, right? Can't be wrong if you gave it to me and signed off on it. So that's what you want to do for every physician, and that's what we're moving to here now. It's not that difficult to do, and it's probably not as expensive as you think. If this happens, they can't say it's not risk stratified. And if they do, you can then say, well, we're going to use your national databases, which most of us have now that we use, and you can stand on the shoulders of that and save money. Then you finally get to what all the administrators here want, and that's change, behavioral change. So we've done some things here for on-time starts. We've done some things here where me and my thoracic surgeons took our tray and got rid of about 90% of our instruments and reduced them down. Incredibly simple, took a few hours, saved a huge amount of money. That is reduction in variation. The way to reduce cost is to tell that big, rich, famous, I'll say, neurosurgeon that the needle driver with the gold handle, you probably don't need that, man. Probably the one your partner's using that's aluminum is just as good. I don't hear too many surgeons complaining about the weight of their needle driver, but yet I've heard it when I've talked to surgeons. Get rid of all the nonsense, get rid of the prima donnas, get rid of our variability, and that's how you reduce costs. Sutures, artificial knees, artificial heart valves, staplers, we're all going to do it the same. We're all different in a way, but the process can be similar. So what are the best aligned metrics? Well, time. Time is the one commodity that is the most valuable commodity we have, and the one that we wish we had more of. And I've already ticked off Dr. Fernandy, he's leaving. Will, has it been that bad, Will?
You told me he wasn't coming.
Well, no, his brother wasn't coming. He was coming. Thank you, Dr. Fernandy. So time, yes, time is the most critical thing.
Now you can be honest now that Will.
Yeah, I can, right. And the reason is surgeons hate delays and we're inherently impatient. If you tell us we get the operation done quicker, get home quicker, get another room in, fix the turnover time, we love that. That's our love language. And time is not measured by that, it's actually measured by that now. And why do administrators like that? Time is money. 1 minute in the operating room in Alabama is 110 minutes. In New York City, it's probably $130. It was interesting to hear Larry said he measures it in 15 minutes. We try to measure it in 1 minute, but I guess we can do the math, even though we're in Alabama, we can do that. Time equals money. So now you've aligned the administrators with the surgeons. Man, the surgeons want to go fast. We want to get the patient in and out. And so the metrics you start with are some that do with time, because less than half our time in an operative day is actually operating. So, operative time. Now, maybe you're disincentivizing the surgeon to teach. We can't do that, and I'll show you ways we can do that in the last part of the talk. Turnover time, pre-incision time. There's an article that comes out in this month's Annals. We have 2 articles in this month's Annals of Thoracic Surgery. The first one is called, I don't remember, Decreasing the Pre-Incision Time for Pulmonary Lobectomy, the process of lean and value stream mapping. And so this is using what we've been doing in business for 40 years and applying it to the operating room. Lean and value stream mapping. Saves money and saves time. In addition, we've come up with these terms. The RVU gap time. Surgeons like that, they like that. Because now they ain't making money, right? You know, if we're not making cookies in that factory, we're not making any money. And surgeons want to make cookies, but yet most of the time the factory shut the hell down. That we can fix. And the reality is, everyone got paid for this. That's not the right metric. That thing that I showed you that was 100% filled is the wrong metric. It's really how many RVUs per OR minute per quality indicator, this little thing that we've come up with, that is the ideal metric. And the quality indicator, which you're dividing by, can be subject to change for different patients. So, surgeons care about this, and this is important. We've already heard what this is. This is related to where you park, if the coffee was warm, and how quickly they get pain medicines, and what the hospital looks like. That doesn't really register with the surgeons as much. But this does. And this, as you just saw, is huge amounts of money. So these are metrics we have to be aligned with. Use national databases, stand on the shoulders, and now the physician can't disagree with this umpire, because that umpire is the one they're reporting their own belief. So what are the results? Well, for thoracic surgery, we are very proud of this. This is this elusive slide. I've had more thoracic surgeons say, can I please see a picture of what a 3-star lobectomy report card looks like? And it's over 3 years, man. It's not a fluke. It's over 3 years. It's the process of looking at your results, looking at your videos, driving a team, having a team that's incredible, having a team of leaderships like we do with our administration and in the OR, giving us the fact that only 12 hospitals in North America got this, 12, and we're one of them over a 3-year period. It's no different than getting that kid of mine to make his eggs better. But he wasn't engaged to do it, was he? And this shows you what happens with branding. And I'm really glad you brought up branding, because you know, surgeons don't want to talk about this, and I don't want this to be about UAB, so I only have one slide about this, but we've had a lot of people come. Today we have visitors from 28 states and from 5 countries. And we turned away, this was intentionally not to be an international conference, we turned away visitors from another 10 countries. And so, because we didn't have enough seats, we only had 318 seats in there. I know, because me and the medical students counted it twice to make sure we wouldn't be embarrassed. This shows you what the hospitals were in their own. So, you change behavior, but let's be honest. I know what you're thinking. This guy Cerfolio, a lot of smoke and mirrors. Some guys, I just can't change them, man. I can't change them. You know, something about them I can't. So, what would a scientist do? You'd go study. Why? What is it about that particular physician that he won't be engaged with change, and the other one would? What's different about them? And so we did this for our on-time starts, because some ORs would get on time, some ORs would engage lean, and some wouldn't. I want to go back to that boy making eggs, because the reality is, that's how you get there. So this is my backyard. And in my backyard, I have a batting cage. This is the same boy on the same day. He didn't go get a PhD. He didn't go get a master's. He wasn't older. He was a few hours older. So it's the same athlete or surgeon on the same day. And he hits righty and lefty, and lefty's having a little problem driving the pitch on the middle to the outside part of the plate the other way for a home run. So we worked on it. On this machine, I can put in fastball, curveball, slider. I got 12 pitches, and I love messing them up with this thing. I can bust them in, I can bust them out, I can do a whole bunch of things. So here he is working lefty. We're throwing 88 miles an hour. That ball's roped. Is this the same kid? Is this the same guy who we couldn't engage on-time start? What's the different kid? He's not moping around. He's engaged in this process. I've got 4 high-speed cameras over here that he can come and watch himself in frame by frame and see where his body is. And my God, he does it all the time. He's totally into this process. So I ask you, is it the surgeon characteristics that avoids the engagement, or is it the process and what he values? All it is a matter, not sending the guy to school to get another degree, engaging them in the process of excellence and showing him that it's important. We studied on-time starts. It wasn't all these other things. It wasn't whether they were a Gemini or a Capricorn. That wasn't it. That didn't make the difference. What made the difference is how we engaged them. Now I know what you're thinking. Oh, money. We bribe them, right? Everybody's going to respond to money. I know what the administrations are thinking. We'll give them a bonus. We'll give them a little cut of it. No, it's not that. It is competitive nature of everybody in this room. If you put up a metric and you put me ninth on that list in front of my colleagues, I'm going to go fix that tonight. I ain't going to be ninth next time you show that. I don't want to be last in anything. No one in the room wants to be last. You didn't get here being last. Everybody got here by being first. It costs nothing to publicly report how people are doing in their metrics. Nothing. And the institutions that put up surgeons, 1, 2, 3, 4, 5, you're full of baloney. Put up Robert Cerfolio, you stink, you're in last. I'll go home and fix it. My team and I will meet that night, we'll figure out the process and we'll fix it. It doesn't have to be to bribe them. And that leads to a culture change, and that leads to alignment. And that leads to peer-reviewed articles. One, the cost of segmentectomy, and the other one, how to decrease pre-incision time. Just 2 little examples of projects we've done. The next thing to do is I hate when I sit in the surgeon's lounge. We don't have a little area where we can go to the bathroom. That's not what we have. And the surgeon says to me, you know, the hospital's making a lot of money. The hospital's making a lot of money. I'm like, bro, we're in the same ship. The hospital is us. We are the hospital. You can operate your garage. How are you supposed to work? No, I'm being honest. They don't understand that we're in the same ship on the same rough ocean together. But yet they see it as competition. Oh, are the medical schools doing that? No. What ship do you want to be on? That's the question. Don't complain to be on the first one unless you want to be engaged in the process of building the second one. The hospital, the medical school, the research, we're all in the same ship. So what's the next challenge? The next challenge is now to do this while you teach. Now that we understand what quality is and how to align, how do we do it? Well, we have this paper coming out. It's about coaching and video review. I showed this to Herb. Herb asked me, Dr. Chan asked me to submit it to the Annals of Surgery, but I apologize. I guess I'm in trouble. I'm 0 for 2, huh, bro? I sent this to the Journal of Cardiothoracic already when you gave me that, but when it gets rejected there, then I'll send it. And actually, Metu was one of the reviewers. That's okay, we can tell everybody you chewed it up, but I appreciate your comment. And that's why his time is shrinking for his next lecture. What we did here is you're doing okay. What we did here is we took Lobectomy and we broke it down into 49 specific steps, 49. And I figured I couldn't publish 49, so I think I listed 19 or 18, something like that in the paper, and combined some. Because I could look at what part of the operation the resident was doing wrong. Oh, an 88-mile-an-hour fastball, lefty on the outside part of the plate, we got a problem. Let's spend 20 minutes on that, man. Let's spend 20 minutes on that problem. And that's what we did with these residents. We defined them And then this is a busy slide, but it's really important. The devil's in the data. And I hope, Dr. Vickers, I hope you like this slide. Because it looks at my first 100 loads. And man, I wasn't teaching. This is the percent the general surgical resident did or the thoracic resident. Look, Herb, they didn't like me then. And I'm going to be honest, I wasn't teaching. You know why? I didn't know what the hell I was doing. I'm just being honest. I could not get bad outcomes. You can't hurt somebody's mom or dad because it's your first case. That's not acceptable at any level, especially today. So because I couldn't afford a bad outcome, I had to figure it out. Once I started to figure it out, here they started doing more, but I would go home and tell my son, this resident, he's not good, this guy doesn't want to work, doesn't want to practice, there's something wrong with his hands and his mind. That's what I would think. Turns out, the problem wasn't the resident, the problem was the teacher. I hadn't broken that step down yet and to the level I should have. Once I realized the problem actually was me and not the resident, what happened for lobectomy 200 to 300 to 500? Now we're at 580 lobectomies. They do more and more and more. And the outcomes, which I took off, are the best in the world. With a median blood loss of 20, not a single patient's been transfused, despite conversion rate that started at 14% and is now 0 for the last 130. So the outcomes didn't get worse. But my last 2 or 3 slides, I want to show you what did get worse. My time. And I told you that time was the single most important commodity. And I don't know how to fix this. Maybe senior people in the audience can help me. Because I want to teach, I want to get patient, I want to be better. But when I start to get the operation, my times go up because I taught more. Then I did more complex times, and my times still go up. And time is money, and you got to do a lobe in 2 hours. Our metrics, you got to be finished in 2 hours, which means you got to finish the robotic part in 1 hour and 40 minutes because the medical students close, and it takes them 20 minutes to close 5 little incisions. You may laugh, but look at it. I measure everything I do. It's 19 minutes for medical students to close with you, and I always close with the medical student. So this is something we need to work on. Finally, I end the story with the third and final part of the story. My son's high school season started 2 nights ago, or 3 nights ago. He's had three nights in a row of games. His first time up, they walked him intentionally with a man on first. I'm like, bro, it's the first at bat of the season. Now, he had a pretty good year last year, but he ain't that good. He comes up this time, and it's a tight ball game. No one's on base. It's a 1-run game, and they go to the bullpen, and they bring in a righty. They want to turn him around and make him hit lefty. They know he's a better hitting righty than lefty, but they don't know what we've been doing. They don't know we've been looking at our turnover times. They don't know we've been engaging our surgeons to get better outcomes. They don't know the practice we've done with video. They don't know. They're about to find out. Here he is, 3-0 fastball, outside part of the plate.
Get out.
Touch them all, my
Get out,
brother.
Matthew.
Touch them all.
Get out, that
Even better, he got walked his next time, and now he came up in extra innings, and they brought in a different righty to turn him around lefty. And the coach said, pitch him outside. Okay.
Let's hit that a boy, Matthew.
Double in the gap. And then he
Just
did this
stay at 2.
Cam Newton
Don't
thing
go to
on
3.
second, which I didn't like.
Don't go to 3. Just stay there. Thank you.
In any event, if we work together at teams, if we align our metrics, what happens? Well, the quality is in the eye of the beholder, but the beholder is our payers. And of course, ultimately, our patients. Everybody knows that. We all are in it for the patients. There's a disconnect between the hospital and the doctors, but if we align the metrics, which we can do, and we then generate accurate data, which we're doing here, and we define quality that all the stakeholders, everybody. So the most important part of my team are the guys that turn my room over. They play basketball in my backyard at home, and they're as valuable on my team as my partners are, and I treat them the same. If we realize we're all in this ship together, from the janitor to the CEO to the academic dean of the medical school, and we teach in the real world with time constraints, because I have so many minutes to each one of those specific parts of lobectomy. Quality metrics lead to better outcomes while teaching, and all this can be done with engagement. So with that, I thank you very much, and we'll move on.